Hello, everyone, and thank you for joining us. Welcome to our Public Health Services and Systems Research in Progress webinar series. My name is Anna Hoover, and I am Deputy Director of the National Coordinating Center for PHSSR here at the University of Kentucky, and we are very excited today to have one of our grantees here to talk to us a bit about establishing the empirical foundation for mental health-focused PHSSR. As we know, PHSSR is a wide-ranging field that looks at a lot of mechanisms, and mental health is one that we haven't necessarily explored fully to date. So we're very excited to hear about the work that is going on with Jonathan Purtle, and I'll be introducing the entire team in just a moment. But I want to thank you, all of you on the phone, for joining us today. We are a little over a year into our Research in Progress webinar series, and I think it has been very well received. We've had a lot of nice insights that have been shared via the webinar series. We've also had a lot of interest being raised about upcoming webinars. So as you hear research shared and you have thoughts, whether about follow-up presentations you would like to hear about, or perhaps you have some methodological or dissemination or translation expertise you would like to share with our presenters, by all means, get in touch with us here at the Coordinating Center. We are very happy to help facilitate those conversations. And I want to also thank Ann Kelly, our program manager here at the National Coordinating Center, for all the work that she does in putting together this webinar series. It is my privilege today to introduce to you our panel, who will be talking again about the Empirical Foundation for Mental Health-Focused PHSSR. Our presenter is Jonathan Purtle, DrPH, MPH, MSc. He is an assistant professor in health management and policy at the Drexel University School of Public Health. His research focuses on mixed methods approaches to understanding the translation of mental health research into policy, developing effective science-based advocacy strategies, and designing and evaluating trauma-informed approaches to public health system design and service delivery in urban areas. Dr. Purtle previously served as research director of Drexel University's Center for Nonviolence and Social Justice, a collaboration between the School of Public Health and the College of Medicine, where he oversaw research and evaluation activities for Healing Hurt People, a hospital-based violence intervention program. Prior to serving in this capacity, Dr. Purtle was program manager and health policy analyst at the Drexel School of Public Health, where his research projects focus on PHSSR, racial and ethnic health disparities, healthcare reform, and public health preparedness. Dr. Purtle received his DrPH in Health Management and Policy from the Drexel School of Public Health, a master's degree in sociology from the Universiteit van Amsterdam, I hope I did that justice, and an MPH from Drexel. In addition to his peer-reviewed publications, he is the co-creator and contributor to the Public's Health, a public health blog and column with the Philadelphia Inquirer. Our commentary today will come from two sources. Ann Carol Klassen, PhD, is a professor and associate dean for research at Drexel University School of Public Health. Her public health research is focused on the social determinants of chronic disease disparities and the implementation and evaluation of individual and contextual interventions to reduce patterns of excess burden. Her methodological expertise includes GIS-based and spatial analysis, as well as qualitative and mixed methods for social science research. Dr. Klassen serves as a professor of community health and prevention, and previously was an associate professor of behavioral health sciences at the Johns Hopkins Bloomberg School of Public Health, with a joint appointment in oncology at the Johns Hopkins School of Medicine. Dr. Klassen is widely published, is currently co-leading an expert group on mixed methods research for the Office of Behavioral and Social Science Research at NIH, and chairs the cervical cancer chapter of Maryland CDC-funded Comprehensive Cancer Plan. She received her PhD in Behavioral Sciences and Health Education from Johns Hopkins. And finally, our other panelists today will be Jennifer Kolker, MPH, an Associate Professor and Associate Dean for Public Health Practice at Drexel University School of Public Health. Her public health research interests include education and training, practice, and health department structure and financing. She is an Associate Professor of Health Management and Policy, the Director of the Center for Public Health Practice, and the Co-Director of the Pennsylvania Public Health Training Center, operated in collaboration with the University of Pittsburgh. Prior to joining Drexel in 2004, her work experience included the Philadelphia Department of Public Health, first in HIV/AIDS policy and planning, and later in the Office of the Health Commissioner. Her work is focused on building bridges between academic public health and public health practice within the mission of pursuing public health, human rights, and social justice. Professor Kolker received her master's degree in public health policy and administration from the University of Michigan School of Public Health. We're very excited to have this panel with us. Before I hand the reins over to Dr. Purtle, I do just want to note that we are now in using a new system that we have tried for the last couple of weeks, I think, in which we are asking everyone who's attending who has questions to please type them in the chat box. You see on the lower right-hand corner of your Adobe Connect interface there a chat box, and as questions arise over the course of the presentations, please go ahead and type them in there so that we have those on hand when we get to the Q&A session. Thank you all so much for tuning in. As Anna has pointed out in the chat box, the presentation and bios can be downloaded from the resources box. And with that, I'm going to very happily hand the reins over to Dr. Purtle, Dr. Klassen, and Dr. Kolker, or Professor Kolker.
Great. Thank you so much, and thank you everyone for joining us today. So my talk today will be about establishing the empirical foundation for mental health-focused public health services and systems research. And as my title slide indicates here, we have the classic symbol of the pump handle, very classic to public health, and the chaise lounger, the very classic symbol of mental health and psychology and psychiatry. And as we know, mental health is about much more than the chaise lounger these days, and public health is about a lot more than the pump handle and sanitation. So to get started, I want to provide a little bit of historical context about mental health as public health. We hear a lot about mental health and population mental health in the public health world. And when you look back at the literature, this is something that we've been talking about for a very long time. So back in 1926, Professor Winslow, the then president of the American Public Health Association, declared that it was impossible to consider, even in the briefest summary, the future program of the public health movement without at least some reference to the vast and fertile fields of mental hygiene. He goes on to note that mental hygiene wasn't really being addressed in public health at the time, but he felt hopeful that in the future we would be paying as much attention to mental health as physical health within the realm of public health. So this was back in 1926. In the 1960s, President Kennedy called for what we would call a public health approach to mental illness prevention. And then in the 90s, there were two major Institute of Medicine reports that called for a public health approach to addressing mental health issues. And then in 1999, the first U.S. Surgeon General's report on mental health. So this idea that mental health is within the realm of public health is an idea that's been circulating for quite a while. And today we see this codified in a number of documents at the national level. So mental health is the focus of 12 different Healthy People 2020 objectives. Mental and emotional well-being is one of the 7 priority areas of the National Prevention Strategy. And developing strategies for integrating mental health and mental illness into public health systems is one objective of the Centers for Disease Control and Prevention Disease Action Plan. So I think it's fair to say there's general consensus in the field of public health that mental health is important and something that we should be thinking about. So there is this gap in knowledge, though. So a lot's been written about public health and mental health, but not that much in the field of public health services and systems research. So when I was conceptualizing this project, I went to the PHSSR reference library, which is an awesome resource that's on the University of Kentucky PHSSR website. There are over 1,000 publications in there that are related, have been deemed related to public health services and systems research, and they're indexed in various ways and very searchable. And what I found was only 5 relevant results that were assigned the keywords mental health and or behavioral health and or psychological. And 3 of these 5 were scholarship, people talking about the importance of mental health to public health services and systems, and only 2 were empirical. One was focused on resilience after disaster, psychological resilience, and the other was focused on coordinating services for individuals with severe mental illness. So we see this gap here when it comes to empirical research around the public health system and mental health. But the literature tells us that local health departments have great potential, in theory at least, to improve population mental health. And we can do this by integrating issues related to mental health into the 10 essential public health services. So things like mental health surveillance, policy advocacy to address the social determinants of mental health, stigma reduction. These are things that we can do by integrating them into the essential public health services and things that a lot of local health departments are already doing. And I believe that local health departments can also complement what are often purely clinical efforts of local departments of behavioral health. And we could see now as an opportune time to consider local health departments' role in population mental health within the context of local health department accreditation and also the full implementation of the Patient Protection and Affordable Care Act, as local health departments kind of reconsider their roles and recalibrate and reconsider priorities. So my study has two parts. The first part is purely quantitative. So the quantitative study, which I'll talk about first, it was, no one's really looked at this empirically before, so it's a largely descriptive exploratory quantitative study. So I wanted to describe the prevalence and correlates of local health department activities to address mental health in the United States, and then estimate the proportion of the U.S. population covered by these local health department activities to address mental health. And I also wanted to identify associations between the types of mental health activities that local health departments perform and the characteristics of these local health departments. So that part of the study kind of gave me a broad overview, and I'll present those results and the state of what's going on, but it doesn't provide a lot of context and a lot of detail. So I also conducted a qualitative study where I wanted to explore local health departments' officials' perceptions of mental health as a public health issue. I wanted to get more information about the activities that local health departments perform to address mental health, and also start to identify barriers and facilitators to these activities. So first, the quantitative study. So I used the 2013 National Profile of Local Health Department Study, which is administered by NACCHO. I'll refer to it as the Profile Study. The core survey is sent to over 2,500 local health departments with a response rate of 78%. And there are two other supplemental modules, Module 1 and Module 2. Module 2 was sent to a representative sample of 596 local health departments with a response rate of 82%. And for the purposes of this study, I limited my analysis to the respondents that completed Module 2 because Module 2 contained the most questions about mental health. So I selected 8 variables from the data set that were explicitly focused on mental health. One of these variables assessed the provision or contracting of direct mental health services. 5 assessed local health department activities to ensure access to mental health services. 1 assessed the provision or contracting of population-based activities to prevent mental illness. That was the language used in the question. And 1 that assessed policy and advocacy activities in the area of mental health. So I looked at whether or not each local health department performed each of these activities and then created a dummy variable in which I assigned each local health department to the number of mental health activities it performed. So 0 to 8, and then I also dichotomized those, so each local health department was 0, more than 1, more than 2, so on and so forth. So I also looked at local health department characteristics. I selected my variables using Handler and colleagues framework for the measurement of public health system performance. For macro environmental factors, I looked at the population size of the local health department jurisdiction and the U.S. census region in which it was located. For structural capacity, I looked at the number of full-time equivalent local health department staff per 10,000 population served, and I classified these according to their quartile rank. And for process factors, I was curious about how mental health activities differed according to whether or not the local health department directly provided or contracts primary care services or substance abuse services. I used the Module 2 sampling weights. I first generated univariate descriptive statistics to just generally get a sense of what was going on. Then bivariate analyses, I conducted chi-square tests to identify associations between each measure of mental health activity and local health department characteristics. Then I performed multivariate logistic regression to identify associations between different mental health activities after controlling for all of my covariates. And I used SPSS for my analyses. So the results. So this slide shows the proportion of local health departments in the United States stratified by the number of mental health activities they performed. That's the orange bar. And the yellow bar is the proportion of the U.S. population living in jurisdictions where these activities are performed. So as you see, a main finding is most local health departments in the United States perform at least one activity to address mental health. 55.8 of them do this, and the majority of the United States population live in these jurisdictions. We also see that about a fifth of local health departments in the United States perform 4 or more activities to address mental health, with over a third of the U.S. population living in them. So this is big picture United States, but let's take a look when we start stratifying by different variables. So when you look at all health departments in the U.S., on average, a local health department performed 1.8 activities to address mental health. When you look separately and you only look at local health departments that did perform 1 or more mental health activities, that average ups to just about 3. So stratifying by region, these are the 4 major U.S. Census regions. We see that local health departments located in the Midwest perform the most, the greatest number of mental health activities, and local health departments in the West perform the East. A significant difference here is between local health departments in the Midwest versus the West. The other differences really aren't that dramatic and are not significant. So this similarly is looking at the proportion of local health departments in each census region that perform 5 or more mental health activities. So I see 5 or more activities as meaning that the local health department really is actively engaged in mental health. So almost a quarter of the local health departments in the Midwest perform 5 or more activities, and only just about 10% of local health departments in the West. So this is looking at the mean number of mental health activities performed stratified by the jurisdiction population size. And here we see this kind of bell curve, right? So local health departments with the smallest populations perform the fewest number of activities. These mid-sized local health departments serving populations between 50,000 to 99,000 perform the most, very similar to those that serve between 100,000 and 499,000. And then those large local health departments that serve populations over 500,000 perform a fewer numbers than those in the middle. So I kind of interpret this as thinking the ones on the far left, these smaller health departments serving smaller populations have fewer resources, that explaining that. And then as we get into these larger health departments, these health departments serving populations over 500,000, I'm more inclined to think that there is definitely a behavioral health entity in that jurisdiction who is doing a lot. But this is really, really speculation, but the rest of the analysis sheds some additional light. So this is the number of mental health activities performed stratified by whether or not the local health department provided or contract primary care services or substance abuse services. So among all local health departments that provided or contracted primary care services, these performed an average of 2.5 mental health activities. When we just look at the local health departments who performed at least one activity to address mental health and provided contracted primary care services, that ups to almost 4. What's interesting here is when we look at all local health departments that provided substance abuse services, the mean is significantly lower than it is for those that provided primary care services. So it's down to 1.8. But when we look at those local health departments that provided substance abuse services and performed 1 or more mental health activities, the average number of mental health activities goes up to 4, pretty much equivalent to what it was for primary care services. So this is very similar. This is looking at the proportion of local health departments when looking at all local health departments that provide direct primary care services. 26% of them perform 5 or more mental health activities. When just looking at local health departments that provide substance abuse services, only 15% of them perform 5 or more mental health activities, which is much closer to the average, where those that provide primary care services are performing a greater proportion are performing 5 or more mental health activities. So shifting gears here, that first batch of results was looking at the numbers of mental health activities performed, so kind of the cumulative measure of involvement. Here we're looking specifically at what the different mental health activities are. So you can see that the mental health activity most frequently performed is assessing gaps in the access to mental health services, with about 40% of local health departments performing that activity. Implementing strategies to increase access to mental health services was the second most frequent activity, and providing direct mental health services, only about 14% of local health departments did that. But still, we see about a quarter of the U.S. population lives in a jurisdiction where the local health department is providing or contracting direct mental health services, and about half of the U.S. population is residing in a jurisdiction where the local health department assesses gaps in the access to mental health services. So now looking at these results stratified by U.S. Census region. So local health departments in the Northeast were significantly more likely to report providing, contracting direct mental health services than local health departments in other regions. And conversely, local health departments in the West were less likely to provide or contract direct mental health services, with only about 9% of local health departments in the West performing that activity. So this is also by U.S. Census region, but this time looking at the proportion of local health departments that reported engaging in mental health policy or advocacy activities. And here we see that the highest proportion is in the South, and that local health departments in the South were significantly more likely to engage in this activity than local health departments in other U.S. Census regions, with about a fifth of local health departments in the South performing this activity. So here again, looking at providing, contracting direct mental health services by population size. So here we see this kind of graded relationship where the larger health departments are more likely to engage in this activity, with about a quarter of local health departments serving populations of 500,000 or more performing this activity. So here are the results stratified by whether or not the local health department provided contracted direct primary care services or substance abuse services, looking at the provision of mental health services as kind of the outcome variable. So we see that about 30% of local health departments that provide direct primary care services also provide direct mental health services, and that these local health departments that provide direct primary care services are significantly more likely to provide direct mental health services than those that do not provide primary care services. We also see that local health departments that provide direct substance abuse services are more likely to provide direct mental health services, but a proportion smaller than those when just looking at primary care. So here again, stratifying by local health departments that provide direct primary care services or provide direct substance abuse services, and looking at the proportion of local health departments within these categories that implemented population-based primary prevention activities to address mental illness. And again, here we see that local health departments that provide primary care services are more likely, about 30%, also perform primary prevention activities to address mental illness, a smaller proportion in substance abuse. And the local health departments that provide substance abuse services are not significantly more likely to perform primary prevention activities to address mental illness. So lastly, I then performed multivariate logistic regression to identify independent associations between the mental health activities performed. And what I found was that all of the mental health activities were significantly associated with each other, right? So that means they cluster together. So after controlling for the performance of other mental health activities and performing for covariates that were identified as being significant in the bivariate analyses I just presented, I looked for independent associations. So when looking at local health departments that reported providing contracting direct mental health services. So I found that 61% of local health departments that provided direct mental health services also implemented population-based primary prevention activities to address mental illness. And after adjusting for covariates, these local health departments were about 7 times more likely to perform these population-based activities than local health departments that did not provide or contract mental health services. I found that over 50% of local health departments that provided direct mental health services also engaged in policy advocacy activities to address mental health, and that these local health departments were about 3 times more likely. Then looking at local health departments that reported engaging in policy or advocacy activities to address mental health, I found that about 75% of those also reported assessing gaps in access to mental health services, and that those were significantly more likely to engage in that activity than those that did not. So kind of what are the main takeaways here? So one is that I think it's fair to say that many local health departments are actively engaged in activities to address mental health. I didn't have any hypothesis really coming into this study, but I was surprised by the level of activity that I found. So most local health departments in the United States do something to address mental health. They perform at least one activity, and over a quarter of local health departments in the United States performed 3 or more activities. So, my study sheds absolutely no light on the extent to which these activities improve population mental health in any way, and I think that's definitely an area for future research. I also think there's a need for a distillation and identification for evidence-based population mental health activities that local health departments can perform. There's a lot in the literature about the importance of addressing mental health and even the importance of local health departments addressing mental health, but there's a lot less about what sorts of concrete things local health departments can do in this domain. And another main finding was I found that local health departments that were engaged in clinical services, so both primary care services, substance abuse services, direct mental health services, were more likely to be engaged in these population-based activities. So things like policy advocacy and also engaging in population-based mental illness prevention. And I think there's a need for more research that kind of explores the association and interrelationship between local health departments performing clinical activities and then also performing population-based activities related to mental health, and kind of what that association might be and what if there is a mechanism in there and what that mechanism may be. So that is kind of the quick overview of the quantitative study, which provided a broad, kind of high-level descriptive overview of what local health departments do to address mental health, and really the frequency of activities and identifying some characteristics that are associated with these activities. It didn't provide much information about the nature of these activities, and also it didn't provide, I had a lot of questions about kind of the nuances about why local health departments were engaging in mental health activities and their relationships with other entities in their jurisdiction who address mental health. So here's where the qualitative study comes in. So to date, I've conducted 19 interviews with 26 different people from 19 local health departments across the U.S. I plan to conduct about 5 more interviews in the next few weeks. Each interview was about 30 minutes in duration. Some were a little bit shorter, but most were longer. Some were over an hour. Some people were very passionate and had a whole lot to say on the topic. I purposely selected the local health departments I've recruited to participate in these interviews. I wanted diversity in geographic region, population size, and also the number of mental health activities performed. So going back to that variable I created from my analysis of the profile study data set. All of my interviews have been transcribed and ported into in vivo for analysis. We're using thematic content analysis, which is in progress, but I'll present some preliminary findings today. And of course, this was approved by the Drexel University Institutional Review Board. So one main finding was that my respondents really almost resoundingly expressed that they saw mental health as a public health issue. And I'm just going to present some illustrative quotes throughout this portion of the presentation, and I'm not going to read through all of them, but I'm just going to point out some aspects of each. So as this one respondent said, mental health is on our mind all the time, and they're really trying to think about it. Someone else acknowledged a shift in how public health and local health departments are thinking about mental health. As they said, I mean, even within the field of public health, people see mental illness as part of overall health now. It's not just something geared towards crazy people, which how they used to phrase it back in the day. So a theme that came up in the majority of the interviews was that mental health was identified as a need and a priority in community health needs assessment and community health improvement plan processes. That's something I found very interesting and didn't necessarily expect to find. So I found this quote very interesting, but when it all whittles down to in the community health improvement plan, one of them was mental health. So this was a priority. This was the number one priority identified. After that priority was access to quality health care, and third was chronic disease. So the community identified mental health as the number one issue that they thought the local health department should be addressing. As this other person said, in their CHIP plan, there were 3 areas that emerged as a priority, and one of those areas was mental health and wellness. And the number of respondents in the context of talking about the community health needs assessment, they talked about using data, but a lot of them spoke about their community meetings and their stakeholder meetings and how the community really emphasized, often loudly, the need for mental health to be addressed in the population. As this one person said, it's unacceptable, this is the community speaking, it's unacceptable for you to just wait until we collapse in the street. This is not okay. So I asked a number of questions about the impact of the Affordable Care Act on local health department activities to address mental health, and I heard a wide range of things. So one category was benefits. Some people said that the ACA has been great for population mental health. There have been more people enrolled, more people insured, and as a result, they have greater access to direct mental health services and also greater access to primary care services. And this respondent saw that integration of primary care and direct mental health services is being really important, and the ACA extending that to a large proportion of the population. Some people expressed challenges. So I heard from at least 4 respondents that with the expansion of Medicaid, a number of people the local health department was serving, they were no longer able to serve. So they had funds and a mandate to provide some mental health services to people who were uninsured. They had to be uninsured. Now they're finding that a large proportion of that population has Medicaid, and then technically they no longer qualify for those public services. So some local health departments were able to change policy to allow them to now provide these services. Others were still working it out and figuring out how they can serve these people through Medicaid. Some people said it was mixed. So this one person said it was positive and negative. They saw it as good that coverage was expanded to a large proportion of the population, and that population now has access to mental health services. But they also saw that in their jurisdiction, the ACA brought a real focus on clinical care and kind of took away from the population-based perspective that this respondent really feels is more core to public health. So almost all of the respondents brought up the issue of barriers to their people in their population accessing mental health services. So overwhelmingly, an insufficient number of mental health providers in the jurisdiction was identified as an issue. Quite simply, there's not enough providers for the amount of mental disease in the region. One person spoke about how their role at their local health department in addressing mental health is they provide referrals, but there are very few providers to see these individuals. A number of people spoke about Medicaid and administrative challenges related to reimbursement. So not just the low reimbursement rate, but also kind of the more technical administrative stuff. So as this one person said, for a mental health provider to accept Medicaid in their state, they have to have electronic health records, and a large proportion of the mental health workforce, particularly the proportion that does accept Medicaid for mental health services, doesn't have electronic health records. So that was an issue. And also lack of services for people without severe mental illness. So a number of respondents spoke to how for people with severe mental illness like schizophrenia, there were services, but for people with more low-lying mental health issues like depression and anxiety disorders, there really wasn't much out there. One respondent went on for a while about how there was no WellCare system in mental health. There's no such thing as a WellCare visit for mental health. And also this idea that, this local health department respondent said they've known for a long time about these people who are not sick enough to really light up on the switchboard, but they're not really functional. They're quote unquote just a step away from having a total collapse. So this idea that there needs to be more in place for people with less severe mental health conditions in the context of services. So a number of respondents spoke about challenges to collaborating with local behavioral health agencies in their region. One theme was that the public health people said that the behavioral health agencies really have this individual clinical focus. So as this person said, for behavioral health, you have to have a person in front of you, right? So often in behavioral health, it's very fee-for-service, and they don't do much, and they don't really have a mandate to do much. It's not really direct service oriented. And as a result, they really don't do much population level anything. One local health respondent was more irritated. She said, well, here's a pet peeve of mine. Behavioral health really does zero population data anything. This respondent was irritated by the fact that local behavioral health departments are so focused on individuals and clinical services and not really thinking in the population way. And in a similar vein, respondents expressed that local health departments and local behavioral health agencies often have divergent perspectives. And again, going back to this idea about local health departments thinking in terms of populations and behavioral health thinking more in terms of individual patients and clinical encounters. So this one respondent expressed being irritated about the lack of upstream work going on in behavioral health and acknowledging that their bread and butter is really serving people who walk through the door, which is probably quite true, and that is often behavioral health agencies' mandate and really just what they have the resources to do. And this last quote is from a respondent where mental health and public health had become very integrated. Two organizations merged within the past 5 years, and the respondent spoke about how it was kind of challenging for the mental health people to then see things through this public health lens post-integration of the departments. And lastly, impediments to local health departments being involved in mental health. So of course, local health departments have competing priorities. They have a lot on their plate and a lot they have to do. So this one respondent was talking about all the challenges in terms of funding their local health department is saying it is tasked to do. And they said how mental health is not an essential local public health service. So addressing mental health in any way really isn't where they're at right now. They were really more focused on maternal health, vaccination, things like that. And they didn't have the resources to address mental health, so they really weren't doing anything, even though they did see it as important. And somebody else, and a number of respondents actually, kind of acknowledged how mental health was someone else's job, someone else being behavioral health entities within the region. So respondents would say it's important, but the local health department has a lot of other things to do, and if they don't address mental health, something is still going to get done. It's still someone else's job. So it was seen as kind of absolving them from responsibility and allowing them to address the things that they really are mandated to address. And then something that came up that was pretty interesting was this idea of professional boundaries and turf issues between local public health and local behavioral health. So as this respondent said very clearly, I'm not looking to take mental health from another agency. And as this respondent said, we don't get into it as deeply because of political reasons. We never wanted it to be seen like we're stepping on their toes per se, there being the local behavioral health agency. So these are my preliminary results. We're still doing analysis and still kind of distilling out what the core themes are and what all of this means. One thing I think is interesting is that the overwhelming majority of respondents talked about how mental health came up in the community health needs assessment process. And a number of these local health departments are pursuing accreditation or are accredited and this is why they conducted this very rigorous community health needs assessment. So I think an idea to consider is that mental health may be emerging as a new priority for local health departments as they engage in these rigorous community health needs assessment processes and hear from the community that mental health is something that they should address. So looking at the other literature for a bit, there is some support for this hypothesis. So Liu and colleague did a study using 2010 profile study data, and they found that 32% of local health departments performed at least one of 3 activities to ensure access to mental health care services. It was compared to 45% for local health departments engaging in one of these 3 activities for dental care and about 66% for medical care. So I then looked at these same 3 variables. I went back to my data set, looked at these same 3 variables looking at the 2013 profile study data set, and I found that now the proportion of local health departments that reported performing one of these 3 activities to ensure access to mental health services increased from 32% to 46%, while the proportion of local health departments engaging in these activities to address dental care or medical care really remained the same. So the proportion remained the same for dental care and medical care between 2010 and 2013, while it increased from 32% to 46% within this time period. So I see this as providing some support for the hypothesis that the community health needs assessment process, which is becoming more rigorous because of the accreditation movement, is leading local health departments to kind of consider more thoroughly and systematically look at what their role in addressing mental health might be. So lastly, next steps. So I'm in the process of completing my interviews. I actually have another one at 2 o'clock today, and I'm going to do a couple more in the next few days. We'll complete the qualitative analysis, and then this will be wrapped up in 3 publications. One will be focused on the quantitative study. The other will be a qualitative study, more broad in scope. And lastly, a qualitative study focused on trauma-informed public health practice. So this is a theme that emerged from the interviews that I didn't get into the presentation today, but the overwhelming majority of respondents talked about the idea of trauma-informed care and trauma-informed practice and what that means to public health. So I find this is something I'm very interested in, so this will also be a paper in and of itself, kind of hearing the voices of respondents and thinking critically about what this idea of trauma-informed practice might mean for local health departments in a very concrete sense. And I'll be presenting some of these findings at the APHA conference in Chicago, a paper or a presentation focused on the variable of mental illness prevention activities by local health departments. So thank you, and now I want to hand the reins over to my primary research mentor on this, Dr. Ann Carol Klassen.
So thank you, Jonathan. That gives us a great deal to think about. And I wanted to just mention some of the next steps or additional research questions that occurred to me from listening to your presentation. And the first thing that I think has come out very strongly is a unique role for public health in surveillance, and that there may be tensions around the service delivery role, but if we go back to your original metaphor of the pump handle, and when we know that we have an outbreak or a change at the population level, that public health really serves a unique role in being able to create population-level surveillance information, and that we historically in public health have seen that for infectious disease, now for chronic disease, and it for mental health I think can play a very important role. So even the smallest local health departments I think are speaking to you as end users, and they're asking for locally relevant data, not just of service use, but of mental health more broadly understood. We have mechanisms through BRFIS and other data for large, broad brush resources, but there are issues with the size of the population and the indicators, and those mechanisms may not be sensitive enough to really monitor local change or local demand. health departments, I think, can advocate across agencies for special questions to be addressed and certainly for pushing for broader resources to be used. But I think local health departments and certainly state health departments should remember their unique roles as the producers of population-level data. Historically, that's a very strong role of health departments to think about creative methodologies to combine, synthesize, and estimate, even with some uncertainty, what the population mental health and health needs are. It's really, if we think back, health departments have been unique voices for new methodologies, for new indicators that are broader than just clinical need, and for shaping the discourse about how we know what we know at the population level about health indicators. And again, partnering but not duplicating the role of service providers. They're not payers, and they can't just look at service use. One question why a local health department would want to take on the surveillance challenge when it can draw on resources that might be used for service delivery is that really this is the best way for monitoring and evaluation. So change due to local need, due to population change, due to events such as change in service availability or crises, trauma. Again, they can also serve, if they have good surveillance data, as strategic evaluators. So if their policy or planning changes, they can evaluate the structure of service delivery and its outcomes. In fact, some of the models you're talking about here in terms of partnerships with behavioral health agencies and contracted versus directly delivered services really can't be evaluated at the population level unless we have surveillance data. So again, an additional thought is for workforce training needs. How can a local health department inform the workforce needs of a jurisdiction if it doesn't have good surveillance data at hand? So with that, I'm going to stop talking about research needs and allow my colleague to talk about policy and practice implications.
Thank you, Jonathan and Anne. This is a great presentation. And I have to say, from a practice point of view, nothing about Jonathan's findings surprised me at all, particularly the community comments about mental health. Having been involved in a lot of these community health improvement processes, some accreditation work, I'm finding that more and more on-the-ground public health is realizing that the concept of assuring the conditions under which people can be healthy includes mental health, even if it was not a part of core public health back when I was working in health departments. There's more of an understanding on the ground that being mentally healthy is necessary to improve physical health at the individual and population level. And so in many ways, the rest of the work that we do needs to catch up with that. And we need to include and incorporate mental health into what we do, into the nomenclature of public health, into the 10 essential services. We can no longer afford to view it as a sort of specialty activity. It really needs to be intrinsic into the overall function of public health. And I think people know that, and public health practitioners and leadership know that, but some of the bigger systems and standards and documents don't yet reflect that in a way that's helpful and functional at the local public health level. So a couple of quick examples. I think there's a strong need for better tools and guidance from things coming out of NACCHO, coming out of RWJ, things that can really help local health departments think about how to look at mental health prevention, about prevention around mental illness, how to look at access to services, how to look at surveillance. But people really need some better structures to do that. If you think about HIV and AIDS and chronic disease prevention, there's a wealth of resources out there for local public health on how to best do that and what the best practices are. And there's much, much less out there around mental health. So we need to give local health departments, I think, more tools and guidance on how to do this work, how to incorporate mental health into their work, and how to measure what they're doing for that effectiveness. Similarly, Jonathan talked about accreditation, and certainly public health accreditation is taking off. More and more health departments are looking at accreditation, therefore conducting these community health improvement plans, but looking at what they do and how they do it. And because we have historically looked at mental health as simply a clinical service, it's really not part of the FAB mindset, the Public Health Accreditation Board mindset. And it's not part of the standards and measures because it's seen as a clinical activity. But yet we talk about prevention, again, of HIV or prevention of heart disease as core public health. So we need to do some work in that area, because if we're really going to make accreditation a goal of local health departments, then we need to figure out a way to make sure that mental health is part of what a health department sees that it should do.
Thank you, Jonathan, Ann, and Jennifer. We really appreciate your insights. We have quite a queue of questions to get to. I do want to just quickly piggyback on something Professor Kolker was talking about the needs for tools and guidance at the practice level. I think it's important to note that we actually do have local public health departments on this call. So there's clearly a very interested audience in the practice community for this work. I noted in the future steps that publications were primarily mentioned, but I think it's really important to think about how to reach those local public health audiences as well in your dissemination and translation activities. And we at the Coordinating Center will be happy to work with you on thinking through some of those items. But things like NACHO and other, I see ASTO is on the line as well, and other mechanisms for reaching the practice community with some of the findings as you are ready to do so. So I just want to point that out. But I don't want to take too much time on that. I want to get to the questions because we do have, as I mentioned, quite a queue. Going back earlier in the call, we have from Megan Ellis, what is included as an activity for substance abuse at the local health department?
So unfortunately, in terms of the profile study data set, we don't really know. So the variable there, there's a block of questions about direct clinical services, and does it say, did your local health department provide directly, which is one variable, or contract this service in the past year? I combined the contract and direct provision responses because a pretty small proportion contracted. So we really don't know exactly what these substance abuse activities or services are from the survey results. Through the qualitative work, I heard a lot about substance use prevention in schools. So working with schools and school-based health centers to do things around alcohol use prevention and drug use prevention.
Terrific, thank you. And this first question, we have two questions from Priti, and I think the first one may also fall within that scope of the answer for the last question, which is where do these mental health activities fall within the 2009 IOM intervention spectrum, promotion, prevention of disorders, treatment, and maintenance? It appears most of the activities are in the treatment and maintenance category. Is that similarly a data-related issue?
I believe so. So I'm not familiar with the 2009 IOM intervention spectrum, but it's definitely something I look forward to checking out. So thank you for bringing that to my attention.
And her second question is, did you account for states where mental health, substance abuse, and public health are overseen by different state organizations, that is, not under the State Department of Health?
No, I didn't, but I think that's a great area for future research. So because this really hadn't been looked at empirically before, I really took a broad view. I think that's a really important area for future research, looking at the administrative arrangements at the state level where these local health departments are located, because that absolutely has a substantial impact on what is done. Also at the local level, I didn't account for whether or not there was a local public department of behavioral health within that jurisdiction. I wanted to do this, but I found that there is no systematic database or comprehensive database or even list of local behavioral health departments in the United States. There is a National Association of County Behavioral Health Directors, which kind of seems a little bit similar to NACHO, but much, much smaller in scope for behavioral health, but they're pretty limited in their resources. So for example, here in Philadelphia, we have a Philadelphia Department of Public Health, and we have a Philadelphia Department of Behavioral Health. These are two separate entities, and I would really like to know in each of these jurisdictions whether or not there is a separate public behavioral health department. So I think those are really important areas for future research.
And I think that points to something Dr. Klassen was pointing out as well about some of the major implications of this work being around where we need data and where we need data systems and where we should be thinking about how to develop ways of getting the kind of information we need to do really rigorous evaluations of this work.
I think something like the profile study focused on local behavioral health departments would be very valuable to the field.
I think our question from Sheboygan County may also have a similar answer. Sheboygan County is wondering, does this data take into account those local health departments that are a part of the larger Health and Human Services Department?
Yeah, no, that's not something I accounted for, but I agree it's something that's important in future research, yes.
A question from Lava Timsina. Did you also consider provision of mental health services by others, excluding direct service and contracting out? In Module 2, for the year 2013 NACHO profile, there are about 92.61% of the local health departments where mental health services are provided by others. And if you haven't included that, could you share your rationale for excluding the provision of mental health services by others, excluding direct service and contracting out?
Yeah, so it's something I considered at the beginning and kind of thinking how to approach that variable in the data set, and there was also the variable that says these services are not available in our jurisdiction. So in the end, I decided not to include these two variables. One, because the proportion of local health departments reporting that somebody else was doing it in the jurisdiction was so high, because it was 92.6%. And again, I really just trying to get a sense of what it is local health departments do as my research question. I also didn't include these services are not available in the region because that proportion was so small. I don't recall the exact figure, but I think it was somewhere around 2 or 3%, which is important. But for the purpose of this study, I just kind of was taking the broad view.
When you were looking at the structural capacity, did you adjust for FTE of staff focused on mental health at all?
So there is a variable. So in terms of the staffing, there's a variable for behavioral health providers. I believe that's how it's phrased. And in parentheses, it names a number of different things that are considered behavioral health providers. And I believe one of them was HIV, HIV services, not direct clinical services, but it was like HIV management. The other was behavioral health, and the other was substance abuse. So I didn't include those because of the HIV piece, because some of these HIV workers may have a behavioral health, mental health component, but it really wasn't clear. So I just looked at the workforce staffing ratio, looking at all full-time equivalents, and not just looking at those that were not just the staff that were behavioral health staff according to the survey, because that variable seemed too broad to me. That variable was also missing for a really large proportion of respondents. I believe it was missing for something like 60%. So that was another reason I decided not to include it and just kind of had the more aggregate looking at the number of full-time equivalents per 10,000 population.
Thank you. Another question from Prithvi. Would you please clarify your definition for prevention activities in mental health?
Right. So again, this comes down to the data set and how it's worded, and we really don't know. So the variable is worded in the data set as population-based mental illness prevention. So again, the language mental illness as opposed to mental health or behavioral health, that's the language that's used in the survey, and it's not defined in the survey. So this is something I wanted to get at through the qualitative work. I didn't, being respectful of the interview respondents' time and trying to keep the interviews to around 30 minutes, I didn't really get into the exact wording of the questions on the NACHO survey, even though that would be valuable, but I thought that would take up the majority of the time, and oftentimes they wouldn't really remember exactly what they selected and why. I can say that in terms of the qualitative work, when the respondents were speaking about prevention and what they thought of prevention, a lot of it came down to early childhood stuff and adverse childhood experiences and preventing child abuse and neglect and good maternal care and prenatal care. That was overwhelmingly what respondents talked about when they talked about the prevention of mental illness. They were talking about early intervention for children.
I think that actually addresses some of the questions that are coming up, and since we're almost out of time, I'm going to skip ahead a little because that talks a little bit about upstream and prevention work. You've talked a little bit about the definitions of mental health and well-being or illness and how that is being data-driven right now, or driven by your data source, not data-driven, but driven by your data source. Anna Lynn notes in response, I think, to Dr. Klassen's comments that they're trying to identify more surveillance data for mental wellness and resilience instead of or in addition to the mental illness prevalence and service use, and this will help us see different opportunities to promote and prevent well-being. But she also asks if there is a national conversation about well-being and resilience surveillance data, and she'd be curious about those resources. I think I'll just jump in there and say that generally speaking, you might want to look at the Robert Wood Johnson Foundation's Culture of Health initiative. There are a lot of conversations going on about not just related to mental health, but general well-being and resilience across a number of health statuses. And that, I believe there will be some measures coming out around that in the near future, but you might want to have a look at some of those recent RWJF publications and see where there might be some overlap. I'm just rushing through that quickly because we are out of time, and I want to take this opportunity to once again thank Jonathan, Ann, and Jennifer for their terrific insights, for the important work that is being done. We're really looking forward to following this as it continues to develop, and hopefully hearing back some more in the not too distant future about where items are going. I'd also like to thank Jonathan for early in his presentation pointing out that one of the resources he used was the reference library on the PHSSR website. I'd like to encourage those of you who listen into these calls to please visit the PHSSR website, publichealthsystems.org, to see that reference library, also to see other materials that we have available on each of the projects funded through the PHSSR and PBRN initiatives. We really put that out there for your use and hope that you will make use of it. There are also archived webinars from this series, as well as additional information about upcoming webinars, which brings me to coming up on Thursday, June the 18th, one of our pre- and postdoctoral public health delivery awardees, another of our awardees, Charla Smith, at the University of Kansas, will be talking about injury-related infant mortality among vulnerable populations, the role of public health, primary care, and policy. So again, we thank you for joining us today. If you have questions or ideas that have popped up as a result of this webinar, we encourage you to shoot us an email. Have a look here at the other upcoming webinars. You can find that list on our website, publichealthsystems.org.